about a very interesting theme today, and we are starting the journal club, which will be on a monthly basis to cover the key aspects of pediatric endocrinology, especially the research part. So as part of the first session, we'll be focusing about 4 articles. 3 of these are about new therapeutic options, which are available in different scenarios. And 1 is about the diagnostic issues. So we'll try to critically analyze as to what really is being published in the journals is one part, and whether it will change our practice or whether it should change our practice now or in future will be the key themes which we'll try to focus on. So whenever we do a literature analysis, basically we have to look at a scenario as to whether we need to change our practice or not, because that's the most important part, and this is what we'll be focusing about. We have to look at the validity of a particular study, whether it's valid or not, whether that particular study is generalizable or not. So the main aim basically is to see whether we can change our practice based upon a study. So that will depend upon whether the study is valid or not, whether we can generalize that study or not, whether it is a novel work or not. So we see that there are so many papers which are published every time so much research happens. Only a small percentage of them actually change the actual practice. So we have started off with this grand round. You all can go and have a look at our website, learning.growsociety.in, which covers a lot of pediatric endocrine resources, including programs, training programs of fellowship and diploma, which are available. We do a lot of our webinars, including the grand rounds, postgraduate lecture series, and now the journal club, which is there. There are publications which you can access. And this is the mobile application which can be accessed about the influence of BMI on growth hormone peak response in children who have been referred for evaluation for short stature. Now, this is a very, very important area because we keep on doing growth hormone stimulation tests on a routine basis, and there are known interaction of obesity with regards to the overall physiology of growth hormone, and that could have a significant implication in that perspective. So what we'll do in all these 4 reviews is that we'll talk about the key aspects of assessment of a paper. Why was the study done? How was the study done? So with regards to the background, the rationale, and then about the methodology, whether it is appropriate or not. What did they find in that study? And finally, what is the impact which is there and how does it change our clinical practice or not? So why do we need to bother about the impact of BMI standard deviation score on growth hormone secretion? Now we know that obesity has significant impact on the growth hormone IGF axis. With obesity, we have distension in the stomach, which reduces the amount of ghrelin. There is also an increased adipocyte production of free fatty acids, and both of them inhibit the growth hormone releasing hormone. So you have a decreased activity of the growth hormone releasing hormone. This, along with the direct effect of leptin on the somatostatin pathway, results in a low growth hormone state. So obesity is a growth hormone deficient state. You have got a low growth hormone, but it is not actually deficient in terms of the effect of growth hormone. So the levels of growth hormone go down, but the effect is maintained, largely because of the effect of this free fatty acids on the IGF-1 receptor and the impact of insulin resistance because of hepatic deposition of the fat causing insulin resistance, which causes a reduction in IGF-BP, increase in growth hormone binding protein, and an increase in free IGF-1, which culminates in a situation where your growth hormone is less, but your IGF-1 is more and the IGF-1 effect is more. So effectively, obesity is a growth hormone sensitive state as opposed to malnutrition, where you will have a higher growth hormone but a lower level of IGF-1, which is a growth hormone resistant state. So this basically implies that if you have an obese child, they will tend to have a lower growth hormone level. So even if you identify growth hormone deficiency, there may be a theoretical possibility that you are actually overdiagnosing growth hormone deficiency in that setting. So this is very, very important from that regard. So you can have overdiagnosis of growth hormone deficiency in obesity, and whether there is a need for a different pediatric cutoff. Now, adult cutoffs are different. So the Growth Hormone Research Society talks about a separate lower cutoff adjusted for BMI in adults. We don't have any such recommendation in children. So this becomes very, very relevant, whether when we have an obese child who undergoes a growth hormone testing, whether we should use a different cutoff or not becomes relevant in that regards. Now, there is already a meta-analysis on this subject. Abavi et al. Actually looked at the various papers, and what they try to do is to have different levels of cutoffs for different levels of obesity. So what they are saying is that for roughly, you can say that for each category, there is a difference of approximately 1 to 1.5 score in that perspective. So instead of using the cutoff of 7, when you want to use a cutoff of 7, in obesity, they say use a cutoff of 6. So you decline it by 1. If you talk about partial GHD and complete GHD from the GRS, from the Pediatric Endocrine Society guideline, that's 5 and 10, it becomes 8.6 and 4.3. So what they have tried to say is that if you're using 5, 7, and 10 as a criteria for growth hormone deficiency across board, you should lower that to 4.3, 6, and 9 for obese individuals. And for overweight also, it is somewhere in between. So they're talking about a dose response curve with regards to the growth hormone level with level of obesity. Now, this, of course, is a good approach, but the problem here is that when you talk about obesity, there may be +2 standard deviation score or a +4 standard deviation score. So clubbing everybody in a same group may not be appropriate. So what will be more appropriate is to have a specific correction factor, that if your BMI standard deviation score goes up by this much, you decrease your growth hormone by that. So this will make a much more sense. But this really gives us an idea that if you are going across obesity category, you should use a lower cutoff of growth hormone in that regards. And they have advised for these particular equivalent recommendations. So 20 becomes 17.3, 10 becomes 8.6, 7 becomes 6, and 5 becomes 4.3. So this is a sort of a gradient which they have advised. So their main message is that you will firstly diagnose normal growth hormone sufficient individuals as growth hormone deficient if they are obese, and you don't use these correction factors, and that becomes important. So what this study basically looked at was, this was a retrospective study. So of course, we don't expect this to be a prospective study. So they had a lot of data about growth hormone stimulation, which was done. So there were approximately 1,100 children and 1,600 tests which were done, and they had criteria for exclusion. So inclusion criteria was basically somebody who underwent a growth hormone stimulation test. So they were individuals who were short, and then they had underwent either arginine or a glucagon test. Their primary test was usually arginine, and secondary confirmation test was glucagon. Now, individual, of course, who had a syndromic cause, chronic disease, or other parameters were excluded. And very importantly, anybody in which priming had been done was also excluded. I'll tell you about that, but the reason was that most of their individuals were young. So when we'll talk about the mean age, it was like 6. So 90% of them were actually prepubertal and very, very young. So their priming becomes not very important. So what they try to do is that since most of them had not had priming, it may cause more confusion, and that's why they avoided the concept of priming in that regards. So the final data is of around 1,000 children and around 1,400 tests which were done. And out of these, 970 underwent arginine. So as I said, their primary test was arginine. So most of them had the arginine test, and the confirmatory test was more of glucagon. So probably we are looking at arginine as a more important figure as compared to glucagon, because that was the primary test that they were looking at. Now, this is the baseline characteristics, and to look at the primary things, the age was around 7. So these were young individuals generally. They had a growth hormone peak of around 8.77. So what it means is that a good number of individuals were actually not growth hormone deficient. So they had a mix of deficiency as well as sufficiency. So this is important. So when you decide about your study and whether this is applicable to you or not, you need to know out of 100 children whom I sent for growth hormone stimulation, how many are actually positive. So what they are saying is approximately 30-40% were positive. So they were doing with a lower index of suspicion. So somebody who is in, sometimes we tend to be very, very restrictive in terms of control, then we will actually be doing it only in those where the likelihood will be more. So they use a height of 10 centile. So remember, many of these mild cases may also be there in this picture. The mean height SDS was -2.48. Now, if you look at our testing, most patients will be below -3, because generally we don't do much below between -2 to -2. These were, many of them were mild, which was reflected by the fact that a lot of them were normal. So more than 50% were normal. Now, very importantly, more patients were actually normal weight or overweight. Now, if you look at only approximately obesity overweight percentage was very, very low, around 2.5%. So actually, they did not have a significant proportion with obesity. So this could be a question when we talk about validation of these results. They did not have very many patients who were obese. So the basic question is, which may actually reflect the type of growth failure. When we see growth failure, we often say, okay, short and plump. But whether they are actually obese, they are not usually obese. They will be normal weight in most of these scenarios. So this is an important point to remember. So a younger age group, individuals who had a good number of patients who are not actually growth hormone deficient, a reasonable height, but not very compromised height, a large of them being underweight. Now, what they found. So this is basically a univariate correlation with corrected for many other parameters. What they see is that this is the growth hormone maximum level, and this is the BMI standard deviation score on the x-axis. And we can see that there is a clear-cut inverse association we are seeing. So if your BMI SDS is more, your growth hormone level tends to be on the lower side. And this was true for both the arginine test as well as the glucagon test. Now, this was corrected for multiple parameters like age, gender, pubertal status. So which basically means is that one-on-one, not only in the direct front, but when you're correcting for other parameters, you have got a good negative association between growth hormone maximum and BMI standard deviation score. So obese children tend to have a lower peak growth hormone level. This is what they are telling us from that perspective. Now, what it is again, this is basically based upon the univariate and multivariate. So multivariate, we can see the beta value is minus 1.15. So it is significant from that perspective. And what they found was that there was a clear-cut association in terms of growth hormone maximum and BMI when you're correcting it for age, for gender, and the type of test. So basically, it's an important thing which persisted from that regards. Now, what they did was that they tried to see whether, okay, arginine and glucagon, do they behave differently? They did not find. For the same, the results were the same. And as I said, arginine probably were the primary test. So they were the ones in which they were more likely to have, less likely to have deficiency. While glucagon was the secondary. So these were only people who were actually having low levels. Do you get the point? So their first test was arginine. If the arginine was normal, they said, okay, this is not GHD. But if arginine was abnormal, they will then go to glucagon. So glucagon was more severe individuals, but both of them, this persisted. So there was a correlation. And they both have them a same effect of BMI SDS on GH, and glucagon levels were higher compared to arginine. Now, this is important. We know very well that all these stimulation tests are not the same. So what they found that on an average, the glucagon levels were too higher as compared to arginine. So this, they have said that, okay, whether we need to increase the cutoff, but this study is not powered good enough to do that. But we need to be careful. So you can't say that your clonidine 6 is equal to a insulin 6. So glucagon does tend to have a better response. So that's why we have to be cautious in that regards. Now, they also looked at pubertal, which was only 88 individuals. So only 10% were really pubertal. And they found was that there was no difference in the effect of BMI SDS. In fact, pubertal individual, the effect was more. It was, both of them had significant effect, but pubertal individuals, the BMI had a more profound impact on the growth hormone level. So for the same increase in BMI, pubertal individuals will have a more decrease in growth hormone, which will be there. So this is something which was found. So this is an important parameter. Now, what is the nutshell then? So what they said that for every 1 standard deviation score increase in the BMI, you should subtract the growth hormone by 1.1. So they're saying that instead of the previous meta-analysis in which I said, they said, okay, if you are obese, it's like 5 becomes 4 or 4.3. So that sort of a thing. Here they have given a SDS specific score. So they have given a correction factor, which essentially is a regression equation. So basically it's a regression equation. So you say, okay, this is your measured growth hormone minus 1.1 into BMI SDS, and you subtract by that. So for every 1 increase, the growth hormone comes down by 1.1. Now, what does it mean as well? If your BMI comes down, that also becomes a problem. So we have always been talking that with obesity, your growth hormone level comes down. So what this equation will do now is that if your BMI SDS is minus, you will actually subtract from the growth hormone. And many patients who were labeled as normal will become growth hormone deficient. So this is another tricky thing you have to be addressing here. So now this is what they did, which was interesting. So what they said that if you look at the initial diagnosis versus the correction factor, what happens to the diagnostic category? So in 564 who were negative, it did not make a difference. But 103 children would have been diagnosed as GHD if you made the correction. This is because they were undernourished. So in undernourished children, you will label 103 more as GHD. Now, this to me is a big problem. If you use it across board, then you're going to label everybody as growth hormone deficiency. There were only 16. Now, there were very little obese children. So we have discussed already, they were like 2%. So 2% is 20. So I think in all 20, 16 of them were actually labeled as GHD. But when they applied the correction factor, none of them became GHD. This is what is more relevant. So if you have an obese child who comes to you with growth hormone deficiency diagnosis, be more cautious, try to correct that. And if you say 16 out of 20 were actually excluded because of that, that means that you are unnecessarily not diagnosing growth hormone deficiency in that scenario. But the above figure will cause a lot of problem. So in malnourished, you need to probably have a different sort of a study to study that. So we can't say that. And of course, 308 who were diagnosed continued to be diagnosed as GHD. So exclusion in 16, new diagnosis in 103. So you are probably increasing the burden of GHD by around 30%. So this could be a huge problem if you start doing in every malnourished. Suppose somebody is minus 4 standard deviation score in terms of BMI, minus 3, let's say. So then even if his growth hormone level is 12, you will say this actually you have to subtract 3.3, you will make it like 8.7, which I think is not right. But if you have an obese child who is 2 standard deviation score and his growth hormone is 6, then I'll be very wary in making a diagnosis. So you should understand the message. So if your BMI SDS is +2 and your growth hormone is 6, corrected will become somewhere around 8.2. So if your growth hormone is very low, doesn't matter. But if it is in the borderline range and you are obese, then you should worry about this correction. So what they concluded is that there was this equation of minus 1.1, which we are talking about that. And they found was that for 1 standard deviation score rise in BMI, around 13% rise in growth hormone level. So it's another way of putting it in that perspective. So this correction probably reduces false positive in obese children. This is what we are talking about. But the problem is below 0, you will be over-diagnosing a lot of children. So what they are saying essentially is that in this scenario, you need to be bothered about. So mainly use this for obesity, not for malnutrition. There will be a problem. So this was a retrospective study. Of course, getting a prospective study will be very difficult in this sort of a scenario. Pubertal assessment was done through bone age. So they did not have all the pubertal records. So they said if the boys had a bone age about 13 and girls had a bone age about 12, they were pubertal. But I don't think that will make a huge difference because only 10%, most of them were younger in that perspective. Population was younger children and more of underweight. Now, if you look at our children will be slightly older. They will be like 9, 10 years typically when we are doing that. And they will also be underweight. So obese GHDs are not very common. So probably this is not a big problem in terms of what we are facing, but again, relevant issue. So generalizability, the subjects, tests and impact, they were younger children with milder growth failure. So if you have a true growth hormone deficiency, if it's 1, 2, 0, it will not make any difference. But if you have these milder cases, there it will make a difference. So these were milder cases. Tests were arginine and glucagon, and they have already shown that within arginine and glucagon, there is a confusion. So we can't extrapolate 1-to-1 for clonidine. So if you really want to have a cutoff for clonidine, you need to do the study for clonidine, or either a retrospective study and see if BMI makes a difference in that regards or not. So they said that for every 1 SDS BMI rise, 1.1 nanogram can go. So the overall concept from this study is that there is a need of caution in diagnosing growth hormone deficiency in obese individuals with marginal growth hormone levels. That's it. Don't worry about undernourished, don't overcorrect. Otherwise, you will label everybody as growth hormone deficient from that regard. So my impact will be that there is an impact of BMI and GH. There is a negative correlation which is shown, which is pretty much part of the physiology we talked about. But obese individuals, we should consider correction. For non-obese, I think it's not the time to do based upon this information. So what we try to do through this journal club is to look at 4 very relevant issues about how things should change. So for the first paper, we can say that if somebody is obese and has a borderline level of growth hormone deficiency, think twice before labeling them as GHD. Second paper, hypoparathyroidism PTH role at the moment is not giving too much of benefit, and probably it will be too much of a task to give it at the moment unless, as Dhwani talked about, a closed loop sort of a scenario is developed. With regards to the use of CRH receptor antagonist also, it's too early, but this could probably and potentially have a benefit of reducing the dose by maybe 3 to 4 milligram per meter square per day. And finally, liraglutide, definitely if there is diabetes, you will be thinking about that. And now with semaglutide, again, that will be a good option in that perspective. But at the moment, in childhood and adolescent Prader-Willi syndrome, it is of limited benefits. All of you can go and have a look at our website, the courses and the mobile application.